Hi, thank you so much. I think I'm just gaining controls here. Look, I can't start my video, but hopefully you can hear me. Oh, wait, I can start my video. Great.
All
Well,
right. Thank you
thank
very much.
you so much for giving me the opportunity to be with everyone, and apologies for not being there in person. It's my son's 11th birthday, so I have to take him to dinner after this meeting, but I so appreciate the invitation and the opportunity to make sure that I try to help share some of the details on androgen deprivation therapy so that we can all be on the same page. And I think as you heard, this is really a cornerstone for treatment for about half of people with prostate cancer who will get this type of treatment at some point during their care. So I'm going to share my screen. Let's see here, and just go through some of the basics. See if this will present. Uh-oh, I've got the rainbow wheel. Okay, good. There it goes. So we'll go through some of the basics. I'm going to go through kind of how androgen deprivation therapy works and how we give it. And then I'm going to talk about some of the things that it can cause in terms of medical complications, just so that everyone is aware of some of the things that we have to think about when we're using androgen deprivation therapy so that we can keep a person actually well and whole while they're also getting the best treatment for their prostate cancer. And as we finish up, I'm really happy to take questions because I think that sometimes some of the confusion that we can have around these therapies is best kind of fixed by just asking questions and trying to get the right answers here. So let's give a start here. These are my disclosures. I consult with many companies trying to do clinical trials and trying to make sure that we develop therapies properly for people that are going to use them. And so you can see that list here. But now we're getting into the androgen deprivation therapy part. So androgen deprivation therapy is also called ADT. It's also called hormonal therapy. Some people call it chemical castration or pharmacologic castration. There are lots of ways that we use words to describe it, but ADT is the most common term or name for this group of medicines. There are actually two different ways, though, that we do androgen deprivation therapy, or ADT. On the right-hand side, you can actually see that surgery is an option for people who have to be on ADT in forever. And it actually is the removal of the majority of the testis, the part of the testis that makes testosterone. The major organ that makes the most testosterone in any man's body are the testicles. And so you can remove the part of the testicle that actually makes that testosterone. In the past, many years ago, surgeons used to remove the entire testicle, but now they have procedures where they just remove part of it, so that there's still some remaining testicles, so that people don't feel like they've been so changed. Excuse me for 1 second. I have a dog battering the door down. Right. Oh, she left. Okay. So I'm so sorry. She was just going to keep banging, and she must be very excited about androgen deprivation therapy. In any event, surgery is one of the ways that this can happen, and that is a way to avoid the need for shots or for pills. But it is an indefinite form of androgen deprivation therapy. You cannot turn that off. You have that part of your testicle removed, it's forever. And so some people do favor that, but that's less commonly used in the United States. Around the world, it's actually very commonly used because it makes a lot of sense financially, and from an effectiveness standpoint, it is as effective as the medicines. If we look at the left-hand side of this slide, we can see some complicated drawings that are trying to help us understand how the medicines that cause it, or that are part of androgen deprivation therapy, or ADT, work. What you can see at the top part of these pictures, these are brains, and inside the brain, you can see that there's the hypothalamus, and then right below that, there's a pituitary gland. And the pituitary gland is called out in these two diagrams on the left-hand side of this slide with a circle, a black circle around it. That anterior pituitary gland in the brain is where the medicines that we give for ADT actually act in the body. They attach to and stimulate the GnRH receptors in the pituitary gland. There are two forms of medical ADT. One is the agonist, and that's on the left with the black box. The other is the antagonist, which is in the center of the screen with the blue box. And both of these, the agonist and the antagonist, both attach to the GnRH receptor in the pituitary gland in the brain. When the agonist attaches to that receptor, it stimulates the receptor. It stimulates. It causes the pituitary gland to increase the signal to the testes that causes the testes to make testosterone. It says make testosterone, make testosterone, make testosterone. But with that stimulation, it actually overloads the pituitary gland. The pituitary gland downregulates or decreases the amount of that receptor on its surface so that it internalizes it because it's just overwhelmed. And so the signal to the testis then turns off. So it's actually a stimulation of that signal at first, and then within about a week or two, it decreases the signal and turns it off. So there's a surge of testosterone and then a decrease, and then the testes turn off testosterone production. In the middle of the slide, the GnRH antagonist is a block. It's not a stimulus. It's at the same receptor in the pituitary gland in the brain, but it blocks it. So the receptor is actually turned off immediately. So the signal from the receptor down, or the gland down to the testis, is turned off. And there's no testosterone production because the signal is just cut off initially. There's no surge. It just, testosterone just goes down right away. So 3 different ways to get androgen deprivation therapy going in a person: surgery to remove the part of the testicle that makes testosterone. You can use medicines that act in the brain to turn off the signals ultimately that make the pituitary gland tell the testicles to make testosterone. At the end of the day, all of these ways of turning off testosterone production decrease testosterone levels to less than 50 nanograms per deciliter. Why 50? That's what the FDA said is consistent with medical or surgical castration back in the, I think the 60s or the 70s, when they were regulating the drugs that were being developed to decrease testosterone. That's their threshold. The drugs that we use today often are causing patients in my clinic to have testosterones that are less than 20, 10, sometimes even not even really detectable levels of testosterone, which is all right exactly what we want to do, but we have to get under 50. That's the threshold set by the FDA. So these are the methods of the way that we do it. Importantly, and this is a little less exciting diagram, but importantly, we are lowering testosterone, which is on purpose. You can see that all the way in the bottom, there's a red arrow, testosterone levels going down. But because testosterone is actually made into estrogens in men's bodies in some level, estrogen levels in men also go down. And so a lot of the side effects that we see are related not just to low testosterone, but also to really low levels of estrogens in men. So we've got low levels of testosterone, and we've got levels of estrogen that are lower than the levels that we see in postmenopausal women. So really low levels of all of the hormones that we are thinking about. So I talked a little bit about GnRH agonists that cause a surge of testosterone because there's that stimulation of the pituitary gland before a decrease because it's overwhelmed. And then the antagonists that just block that receptor, turn off the pituitary gland, turn off that signal right from the start, testosterone drops. So this is a table just trying to sort of compare those 2 different strategies. The antagonist is in the middle, the agonist is on the right. You can see that they both get to castrate levels of testosterone, that first line on the table. The antagonist does it within a couple days. The agonist does it within 3 to 4 weeks because of the surge before the decrease. There's no flare of testosterone with the antagonist. There is with the agonist. The PSA failure rate, I would say, is basically the same between the 2 of them. They are equal in terms of how well they take care of the cancer. The antagonists come in 2 forms. One's a pill and one's an injection. And the injection antagonist can cause a little more pain. That's an injection that we give in the belly, and it can be irritating to the belly in ways that the agonist, especially when we give it in the backside, it's not as irritating. Cardiovascular complications, it says conflicting data. It's just, there doesn't seem to necessarily be a big difference between the 2, although the antagonist may be a little bit easier on the heart. And the antagonists are given once a month by an injection or by a daily pill. The agonists are given usually every 3 months, although there are formulations for these injections to be given every 1 month, 3 months, 4 months, or 6 months. So that's just some of the differences. In the end, they both treat the prostate cancer equally well. They're basically interchangeable. Sometimes insurance says you have to use one or the other. And there's only one pill option, and that's an antagonist. That's on this slide. Here we can see the GnRH agonists. Those cause the surge before the drop. They have lots of different formulations for different durations, 1 month, 3 months, 4 months, and 6 months. There are multiple brands here, Gaserelin, Leuprolide, Triptorelin, Historelin, and they're all injections. The antagonists, there are 2 of them. One's an injection that you give once a month. It can cause some irritation a little bit more than the others in the belly. The other's a pill. That there's only one pill option, and it's an antagonist. All right, so we've gotten through kind of the basics. Just to reiterate maybe why we do this, prostate cancer cells, I don't think I have a good slide on this, so we'll just stick on here. But prostate cancer cells eat testosterone. It fuels their factories. It helps them to grow, divide, spread. It helps them to do what they want to do, which is actually not what we want them to do. We want them to die. So testosterone is their food or their fuel. They take it into their little factories, they process it, and they spit out PSA protein into the blood. When we take testosterone away, these cells shut down their factories. They start to starve. Some of them will die because they're so dependent on and addicted to that stimulation by testosterone. Others will go into a deep hibernation. Either way, they shut down their factories, PSA decreases. So a good sign when you're starting on ADT is that you see your PSA decrease because you're shutting down the factories, killing some of the cells, and causing others to go to deep hibernation states. When we're using radiation, putting patients on ADT and putting those cells into a deep hibernation makes them very vulnerable to radiation, and they die much more effectively, much more easily. So we really often use ADT with radiation. We sometimes use ADT if the cancer comes back after surgery or radiation. If we see a rising PSA, but the scans don't show any sign of where we could find the prostate cancer, sometimes we start ADT to try to get that PSA to go down and to stop the cancer from growing. And when patients have cancer that has spread to multiple places and we can see it on scans, the backbone of what we do for that person, potentially for the rest of his life, is give him ADT to shut down all those cells and take the food or the fuel that those cancer cells want to eat out of his system. And we add different medicines on top of it to try to kill them over time. But the backbone of everything is to take the food out of the system and never really let it back in, because we never want to give it the opportunity to grow. So ADT can be really helpful in controlling the cancer, but it comes with complications. So one of the things that men have to deal with, actually we all have to deal with, and I could have an equal pie chart for women, is that heart disease is the #1 killer, actually even more so than cancer in the United States, especially among men, but also in women. And one of the things that we have to think about with ADT is that it causes changes in cholesterol and blood sugar, even in the risk of forming clots in some ways, so that people are at higher risk of developing cardiovascular disease when they are on ADT. And the other thing that puts us at higher risk of developing cardiovascular disease is just getting older. So we put these together, and we have to be aware of cardiovascular disease, heart disease, and we have to do something about it if you're on ADT especially. So ADT increases belly fat. So you can see on the scans that I have up top, these are people who are laying on their back, 2 guys. One's not just starting ADT, and then the other one's been on ADT for a while. The gray black stuff that's all around this body, that's all fat in panel B. And that's what happens. ADT, low testosterone, causes people to gain weight around their belly. It's not their fault, and there's definitely no judgment, but we have to do something about it. First is being aware of it and trying to adjust diet and exercise to try to keep that down. We also know ADT increases cholesterol levels, and it messes up the way that people process sugar to some extent, so that the same amount of insulin that can keep your blood sugar under control, natural insulin that we have in our bodies made by our pancreas, it takes more insulin when you're on ADT to keep that blood sugar under control. So it's just harder for the body, has to work harder. We do know that it's especially challenging in people who already have risk factors for heart disease to be on ADT, something for doctors to be aware of to help make sure that things like blood pressure and cholesterol are under control in people, all people, but especially when they're on ADT. And we do know that risk of these factors like blood pressure and high cholesterol is actually really common in people with prostate cancer. So this slide is really talking about a study that was done a number of years ago, looking at 100 men who were walking into a urology clinic for their prostate cancer care, and almost 60% of them had high blood pressure, half of them had high cholesterol, and almost 20% of them had diabetes. Almost 20% of them had coronary artery disease or heart disease. And there were only 4 people out of 100 walking into that clinic who had no cardiovascular risk factors or heart disease risk factors. And this is a group of guys with prostate cancer. So it's really common and something that we need to be aware of. We also know that, as I said, it takes the same amount of insulin to keep the blood sugar at the right level when you have ADT. And there was a study a number of years ago that said that if you are going to be on ADT, as compared to someone not on ADT, you've got a higher risk over your lifetime of developing diabetes. So really something for us to be aware of, again, as doctors and as patients and loved ones, that we talk to our teams and say, hey, screen me for diabetes, watch my blood sugar, make sure that I'm on the right track here. And if I do have diabetes, make sure that my sugars are under control. There are guidelines that were developed by our national organization, the NCCN, that helps us as doctors kind of figure out what are best practices, what should we be doing to take care of people. And they describe a systematic approach to addressing cardiovascular risk, heart disease risk, and diabetes risk through an A, B, C, D, E algorithm. They tell us, first, be aware of this problem. Second, that's A. B is blood pressure control. Get that blood pressure under control. We know we can do it. Work on it. C is making sure cholesterol is at a good level. And also, if people are smoking cigarettes, to stop smoking cigarettes. D is diet and weight management, as well as diagnosis of diabetes or management of diabetes for people that already have it. And E is exercise and making sure that people are staying active, because the best thing that we can do actually to take care of all these risks is to stay physically active. The other thing that I want to mention related to ADT, this is related to the low testosterone levels and the low estrogen levels that happen when we use these medicines, is that bone breakdown happens more quickly than bone buildup in our bodies. And actually in all of us, our bones are constantly building up and breaking down. It's part of the normal process. But when you're on medicines that lower your testosterones, and most importantly, your estrogens in this case, you have more breakdown than you have buildup. So the bones thin over time. And so ADT causes this higher risk of osteoporosis and osteopenia, higher risk of fracture. It's not just an issue for women, it's absolutely an issue for men. And we know that when people do have fractures, the risk of death is actually twice as high for men than it is for women when they have a hip fracture. And that's something that we absolutely want to try to avoid. And hip fracture also, of course, causes loss of mobility, financial challenges, loss of independence, absolutely something to avoid. So being aware of it and taking things like calcium and vitamin D can help to keep the bones strong when we're in this situation. And exercise is really important here. Weight-bearing exercise, just walking, helps to stimulate bone growth. One of the last things I want to mention here is that ADT can cause changes in hormones, like I said, but these can cause an increased risk of things like depression. And depression is already something that is hitting us around the world, especially after COVID. I think it became quite clear that this is one of the challenges we face in our society, in our world. And on the grid or the graphic on the right, you can see that around 40% of people with a cancer diagnosis also have a diagnosis of depression in the United States in this particular analysis that was done a few years ago. And this figure shows us that among people with prostate cancer who were treated with ADT, and the yellow line has a steeper curve, a steeper slope, showing that there's a greater rate of diagnosis of depression than the blue line, and the yellow line is showing people with ADT exposure, and they have a 43% increased risk of having a mood disorder like depression when compared to a group of people in the blue line that do not have ADT exposure. So it's not to say that everyone with ADT exposure gets depression. It's just to say the risk is higher, and it's really important to acknowledge that, because depression is treatable, just like high cholesterol, just like high blood pressure. It's all biologic, and it's something that we can treat. So those same NCCN guidelines tell us, when it's possible that somebody is developing depression, look for other things, look for sleep disorders, find out if they're having other issues, but diagnose the depression if that's what's happening, and give them treatment, whether that's counseling, whether that's exercise, whether that's giving medications. You should do something to help make a difference there. Talking with family can also be helpful, getting involved with support groups, but do something about it and acknowledge it, because it is not a personal failure on the part of the individual with depression. It is a biologic entity and something that we can treat. So just to say that we looked at these images already, can cause a lot of weight gain and changes in things that are not going in the right direction. So we really should be thinking about exercise, safely exercising, but exercise, healthy diet actually helps mind and body. There are lots of resources available to help us with these strategies, including from the Prostate Cancer Foundation. And this is an example of one of their publications. They go through different foods. They talk about different exercise strategies, but you can come up with your own. It's whatever works. I think ultimately ADT causes low testosterone, causes low estrogen too, and the side effects come from both. It's important. It's doing this to help kill prostate cancer cells. But we have to be aware of these complications. And despite all the good effects, we have to think about heart, bones, muscles, blood sugar, mood, all of these things, because we can do something about it to make it better. So just wanted to raise that awareness. And I would love to take some questions and make sure that people feel like their burning questions are answered tonight.
Okay, first thing I want to thank you very much. I know family is important. Everyone here knows how important family is in survivorship, managing your survivorship. So thank you again for that. There's one question that's flying across the screen. Hot flash. Why do men get hot flash?
Yeah, great question. That actually has to do with low estrogen levels. So like I said, it's the side effects of ADT come not just from the low testosterone, they also come from the low estrogen levels that are happening. And just like women going through menopause who have hot flashes when their estrogen levels go down, men get the same thing. There are different cells that act as barometers in our system that sense the amount of estrogens. And when the estrogen levels go low, for whatever reason, we have a lot of difficulty with thermoregulation. That's just a fancy word to me that means how our bodies regulate heat. And we think that we're hot or cold when we're not. And some people get really like sweats, some people shiver and feel cold, but that's all about the estrogen. So there have been some studies that have looked into estrogen patches and different estrogen exposures to try to reduce some hot flashes. There are some wearable devices that people have worn or developed to try to trick the body and make the body think it's cold or hot to try to reduce the hot flashes. So there are different strategies. Nothing is perfect. There are medicines like a medicine called oxybutynin that has been helpful, but I would say that is because of the low estrogen. That's why that's happening.
Okay, and then thank you again for that question, because that was one of the most common questions. And then the one person said that they're taking enzalutamide and they thought enzalutamide was an ADT. Can you help us understand the difference between these novel hormone therapies versus, what would you call them? Just the beginning treatment options? And what's a better way to describe them?
Yeah, so great question. I think the way that doctors describe it, ADTs are those classic medicines that I told you, sort of the backbone that underlies the rest of the treatment that turns off the testes. That is ADT. Hormonal treatments are other things that further limit testosterone from stimulating the cell. And so enzalutamide is a hormonal therapy, but it is not considered ADT. This is really a nuance that I'm still teaching fellows and medical students and things. So not necessarily something that you need to worry about. If you say I'm on ADT and I'm on enzalutamide, that's fine. You may want to just say I'm on enzalutamide if you're talking to somebody and not even put it into a category, because that makes it easier because they can address that specific medicine directly. But it is not technically an ADT because that is really a medicine that turns off the testes, and enzalutamide just blocks testosterone from getting into and signaling the cell.
And I know I'll make this your last one if you would like. Um, there was a question about, you mentioned something about flare or
Yes.
what's a flare?
So the two types of medicines that we use are GnRH agonists and GnRH antagonists. They both act in the brain and the pituitary gland to stop the signal between the pituitary and the testes to make testosterone. The antagonists block it right away. They just turn off the receptor. So there's no signal anymore between the pituitary and the testes. The agonists activate the receptor, but they overactivate it. And so after a week or two of overactivation, the body decreases the receptor, kind of internalizes it to keep it from being stimulated so much. And then the testosterone signal goes down. In the period of time, right after you start a GnRH agonist like Lupron or Zoladex, there's a stimulation, and that causes, for the first few weeks of starting that injection, a flare of testosterone before it decreases. And that is the flare that I'm talking about. It's only for the first few weeks after an injection with a GnRH agonist like Lupron or Zoladex or Goserelin or Leuprolide or Eligard. Those medicines cause an increase of testosterone before it decreases.
So it's not the cancers coming back.
It's not a cancer flare, it's just a testosterone flare. That being said, we usually use a medicine like bicalutamide or Casodex when we start the very first injection to block the flare of testosterone from stimulating and feeding the cancer cells. So when you start the first injection, a lot of times people get 30 days of Casodex or bicalutamide, a pill that you would take once a day. We don't refill it. We don't have to refill it. It's just for the very beginning to block the surge of testosterone from stimulating the cancer cells.
Okay, so that I now understand, and I think that they better understand, because they're on a Lupron plus bacalutamide at the same time.
Yes, yes. That's
Okay.
just to block that initial flare.